Good afternoon and welcome to today's Made by McGill alumni webcast. Where are we headed next with COVID-19? Today, we are fortunate to have with us two familiar McGill faces, both leading experts on global health and infectious disease, to get the latest update on the pandemic and discuss what we ought to be doing to prepare for another winter with the coronavirus and the new Omicron variant. My name is Derek Kassoff, Managing Director of Communications at McGill's Office of University Advancement, and it's Wednesday, December 15th, 2021. With me today are Dr. Marcel Behr, Interim Director of McGill's Infectious Diseases Division, and MI4, the McGill Interdisciplinary Initiative in Infection and Immunity. Welcome, Dr. Behr.
Thank you, Derek. It's good to be back.
Great. Wonderful to have you back. And we also have with us Dr. Timothy Evans, Director of McGill's School of Population and Global Health in our Faculty of Medicine and Health Sciences, and Executive Director of Canada's COVID-19 Immunity Task Force. Welcome back, Dr. Evans.
Thanks, Derek. Great to be back and great to see Marcel again.
Great, wonderful. So before we jump into today's conversation, a reminder that if you're watching live and you have questions for our panelists, you could send them to us by email at aocmcgill@gmail.com, and we'll do our best to address them to our guests. And I'll give that email address again later on. Welcome back, gentlemen, doctors. I was actually looking through my notes as I was preparing for today, and I realized that the last time we had both of you on the same panel was exactly 1 year ago today. And back then I asked you for advice on how we should prepare for the second wave of the pandemic and whether the imminent rollout of vaccines may offer us hope for a quick end to this health crisis in 2021. And yet here we are 12 months later. And things are, I guess we'll discuss it, but maybe a little more bleak than we had hoped. So on the one hand, I know the vast majority of the adult population in Quebec and across Canada has been doubly, and in some cases triply vaccinated now. Hospitalizations from the virus appear to be stable, and the most severe of our public health measures, curfews and strict lockdowns, have been lifted. And yet many would argue that the sense of dread remains high. So maybe we'll start with an overview of where you each think we are headed or where we are in the evolution of the pandemic. So Dr. Evans, maybe I'll start with you if that's all right. We've been at this almost 2 years now. Is it safe to assume that at this point, the very worst of the pandemic is behind us? Or has the emergence of the Omicron variant really set us back to square one in our recovery efforts?
Well, Derek, it's very tough to present a rosy view at this current time, but I would optimistically say that the worst is behind us. And the reason I say that is that we've got an increasing armamentarium of proven proven interventions to address this. And I think we have a track record now, which begins with the Canadian public, who are our best force against the pandemic. Canadians have consistently shown very smart and informed behavior. They heed public health advice. We're in the top 20 globally in terms of vaccine uptake. For the most part, we've avoided the terrible surges on hospitalizations and certainly COVID-related mortality. So I think we're looking forward with building on success. Clearly, we have a stress test to that performance in the context of the Omicron, and I know we'll talk about that coming up. But I think we should always compare ourselves to our neighbors to the south. And if we ever want to feel good, we look there because there they are severely behaviorally challenged when it comes to public health. They disregard good advice. They have had the most vaccines in the world in terms of per capita availability. But I've been unable really to get above 60% full vaccination coverage. And if you look at their 100,000 cases a day and more than 1,000 deaths a day, and compare that to what we have in this country, I think Canadians have a lot to be proud of.
Wow. Well, very well said, I guess. I know we probably do have some American viewers watching today as well, but very interesting to put it in that context for us. And yes, we definitely will come back to a discussion about the Omicron variant in particular. But let me bring in Dr. Behr for an update from your end. Obviously, you're working in the hospital at the MUHC. So I'm curious to get an update from you on what is the current situation on the ground at the MUHC and at other hospitals in Quebec compared to what we may have witnessed at other stages of this pandemic.
So thank you. So as Tim said, I think we are doing better than the last time we spoke 1 year ago. If you just look at the raw numbers of cases reported in Quebec, we're at 2386 today. That's a big number if you go back in the last 18 months. It's actually much higher than the spring of 2020, and it's in the same range as 1 year ago. If you look at the number of hospitalized cases in Quebec, hospitalized cases at the MUHC, we are much lower in 2021 than we were in 2020. And this is, as Tim mentioned, we have better tools now, including the vaccines. So that's sort of the good news. It is better in 2021 than 2020, and I would hope it will be better in 2022 than 2021. The only thing to note is that last year, the rates peaked around January 5th. They came in high before the holidays, and then they even continued into January, and we are not January 5th yet. So we may need another 3 or so weeks to see what happens next. And we'll see what happens to hospitalization pressure at that point.
Right. And so what is the situation in the hospitals beyond COVID? I know that, throughout the last couple of years, we've heard so much about elective surgeries and even in some cases, essential surgeries being delayed because of capacity issues in the hospital. So is this still the case, or is the MUHC and other hospitals, have they managed to sort of get back on track, throughout the healthcare system?
So in the spring of 2020, the hospital was really very, very quiet. And I can remember going to Wen at Cafe Veritas, and he made me a Corona latte. At the time, he was thinking of shutting down the only coffee bar. There was just really very little happening. Certain services were stopped, transplants were being interrupted, and certain operations were being postponed. As of now, if you go to Veritas, I just went there an hour ago, there's a lineup again. There are people, their clinics are open, and the hospital feels busy, and it is serving the population. I see two differences from before COVID. For certain services, the waiting lists are longer than before. So if people are on a waiting list, they may experience that they're waiting longer than they used to. And the other is a more positive. During COVID, we did a lot of telemedicine. We told people, stay home, we'll call you. Now we're seeing more and more patients in person, but we find that some of the patients are quite happy to be seen by telephone, and it works out pretty well. So we're actually adapting the way we do medicine, and there are going to be probably some learnings from this.
Wonderful. So before we go back to Dr. Evans, one more question for you, Dr. Behr. I'm curious about COVID treatments themselves. When the patients do come into the MUHC and other hospitals, I mean, like I said, we've been at this for many, many months now. Are the COVID treatments that we're able to offer, are they any better? Have we learned sort of better ways to treat patients? And as a result, have we seen perhaps higher survival rates, people that maybe would not have survived COVID earlier in the pandemic, or maybe now being treated and sent home? And are we seeing shorter hospital stays for those who do recover?
So at the kind of the scientific level, we have several drugs. We have several monoclonal antibodies. Some work against Omicron, some don't. They don't do the same thing. So the good news at the scientific level, we have options, some for outpatients, some for inpatients. And so we've gone from whether we have treatments to the logistics. Which treatment for whom and where, and these are good challenges to have. At the patient level, we also have learned a lot. We know what doesn't work, so we're not doing the things that are harmful, and we are able to implement treatments better. Comparing treatment success between March 2020 and December 2021 is not straightforward, because a lot of people were admitted for partial COVID, partial other reasons, and there are different ages and different vaccinations. So I don't think you can do a direct head-to-head comparison of the outcomes the way you would like to. But overall, the way we manage COVID now is obviously better informed than it was at the beginning of the pandemic.
Okay, well, that's encouraging to hear for sure. So Dr. Evans, let me go back to you for a moment, if I may. And I want to talk a little bit more in depth about, the latest and potentially more dangerous variant, the one that's on everyone's mind these days, which is Omicron. So I guess my first question to you is, why is this variant so concerning to health experts?
Well, I think there are a number of reasons, but perhaps the most important reason is that Omicron appears to be much, much more transmissible. So in a very short period of time, it's really taken over in many settings to be the dominant variant. I think in London today, it became the dominant variant, taking over from Delta. Certainly the fourth wave in South Africa is almost entirely driven by Omicron. And we're seeing, for example, in Ontario, an expectation that it will be dominant in a number of days in terms of the what's driving the epidemic. So transmissibility is the primary driver of concern. In addition, there are concerns that it might escape the vaccine protection that our vaccines have provided. There's some evidence that the vaccines are less effective, but I think what we're encouraged by is that it doesn't deplete that protection entirely. And secondly, the very strong evidence that by moving to a full vaccine schedule, which is 3 doses, not 2, that you can preserve protection at very respectable rates. So I think that's the second area. The third question that I think is still a very important one, but where the evidence is still not definitive, is whether or not this variant is associated with more severe illness. At the moment, it looks like that's not the case. We have very, very few Omicron-related deaths. The ICUs don't appear to be filling up in places where Omicron is well established. But there are concerns that we will see increases in hospitalizations. And given that so many people could get infected, that could put a huge stress on the hospital system. So I think that's sort of the order of concern. One, definitive increase in transmissibility, concerns about loss of vaccine effectiveness, and some concerns, although still not clear, that this might create a surge on our healthcare system.
Mm-hmm. I'm trying to be optimistic here, and maybe I'm grasping for straws. I'm certainly not the medical expert, but if Omicron turns out to be more, say, harmless than, say, other variants, and it's more transmittable and becomes the dominant strain, could that in some strange way be a good thing and a pathway out of the deadly part of this pandemic? Or is my logic completely way off here?
Derek, I don't think your logic is way off. I think one of the important things is we've already seen variants become dominant, and Delta is dominant at the moment. And so it's going to be replaced by Omicron. But if, in fact, Omicron is very, very transmissible, for example, the modelers in the UK suggest that there were 200,000 cases of Omicron transmission or infection in the United Kingdom today, on this day. And they say that the vast majority of them are asymptomatic. Then it could be that we're moving to a situation where we have a variant that is remarkably less severe and possibly then something where, from a public health perspective related to hospitalizations and ICU and even fatality, that we're moving in the right direction. However, we can't state that definitively at the moment, and I think it's too early to tell. The other thing is we can't lose sight of what might be the long-term effect of infection with the Omicron variant, and we know that there is a long COVID, and I think we're going to have to, if we can prevent infection, I think that would be the preferable course for everybody. So in the uncertainty with respect to long COVID, I think we still have to be very vigilant and try and avoid infection as much as possible.
Okay, great. Very good advice. And I have a few questions coming up about how you might suggest we do that. But let me switch it over back to Dr. Behr again. And maybe we could just take a step back for a minute for the benefit of those like me who are not experts in infectious disease to try to better understand the physiology behind these viruses. And I guess my first question is, how and why do these viruses continue to mutate like they have?
So Derek, viruses mutate. That's just evolution, and RNA viruses change their RNA. And we've known about this from HIV, and we've known about this from the flu. And so it's not particularly surprising that SARS-CoV-2 is evolving. It just depends on when variants happen in the genome. Where was the virus? Where did it land? Where was it dwelling? And depending on where it is, and there are several theories about how Omicron emerged, and some of these you can read through preprints, but nonetheless, it was probably inevitable that after Delta emerged, there would be Omicron, and maybe next we will have Pi, and we'll find out what the Pi variant is. That's what the Greek alphabet tells me should be coming next. I think it's important to note that while it was discovered, Omicron in South Africa, it doesn't mean it came from there. It just tells us that there's a country that does high quality genomic surveillance and actually shared their data when they could have hid their data. And so how it happened, we don't know, but we should be thanking South Africa for having revealed it and not blocking them. That's certainly a key message.
Right, very, very good. So just a follow-up question for you then, Dr. Behr. I mean, if these viruses will continue to mutate, as you've said they do, and as evolution tells us they will, and we're not sure every time a new variant comes out whether the vaccines will work, does this mean that we could be facing a battle of many years between a virus that sort of keeps changing and evolving and vaccine developers that are constantly playing catch-up?
Perhaps. It depends, of course, if all of the variants are of significant medical and public health damage that we need to vaccinate against them. We haven't been vaccinating against the common cold, but maybe we have to revisit that in the future. But from a technical point of view, we already change the flu vaccine every year. And the mRNA vaccine production pipeline was not optimized for pandemics. It was optimized for the rapid treatment of cancer so that you could go from a biopsy to a treatment in 6 weeks. So the technology is there to change the vaccine if it is indicated, and other technologies exist for other vaccines to change them. So I'm optimistic that if we have to change the vaccine, we will, and we will just get the next version next year.
Okay, great. So just a reminder, again, anyone watching live who has any questions for Drs. Evans or Behr, you can send them to us by email at aocmcgill@gmail.com. Dr. Evans, you sort of suggested in your answer earlier that, there's still a lot of unknowns around Omicron. Do you have any sense of when we might know more? Is there sort of a specific time frame in mind where you think definitively the scientific community can come back to us and say, now we know for sure the harmfulness, the vaccine efficacy, or is it just going to be an ongoing sort of, adventure in sleuthing to figure this out?
Well, Derek, first, I just want to rejoin Marcel in his remark about South African scientists, because the reason we know as much as we do is that they had the temerity and foresight to share globally concerning information that their systems picked up, and they have excellent systems, as Marcel indicated. And the reason I want to just pick up on that is I think it's an absolute disgrace that they're being punished with travel sanctions, etc. When any enlightened view of the origins of this virus suggests that it's probably emerged in multiple places at the same time. It really, that spirit of sharing knowledge early so that we all can be prepared is something that we're all benefiting from right now. So I think we really need to see those scientists as heroes and acknowledge them as such, because of their actions, we're in a much better position to face the challenge of Omicron. Having said that, let me say that I think that we are in an era right now with widespread community transmission, and therefore are really looking at relying on our staples, non-pharmaceutical interventions, as well as vaccines to address this. And that comes back to my initial comments, where enlightened behavior, as we've seen Canada is well endowed with, will continue to make a very important input to this situation. So I think this is a new reality. I don't see it being one where we need to be bleak. I think it's one where we have our eyes open. We're learning very rapidly. I'm encouraged that we're not starting up scientific engines from zero. We've got them purring along, and I think this is an opportunity. Let me be a little bit more specific on that. In some of the work we've done in the COVID-19 Immunity Task Force, for example, we said we've got to have a big focus on long-term care residents that were hit very hard in the first wave. We have a whole set of studies going there at the moment, which have been tracking vaccine effectiveness, looking at the wane in antibodies associated following 2 doses. We got recommendations in there to our National Advisory Council on Immunization in September to go ahead with a booster. And those studies are still in the field and can inform what's happening post 3rd dose. And those are the sorts of assets that can be drawn on now to look at how we can continue to protect our seniors or our long-term care residents. And so I think we're in a very, very good position to manage our way through the Omicron era of this pandemic with good science. So I'm positive on that front.
Okay, great.
Can I just add a little addendum to going forward on good science? So it's been literally weeks since the South Africans described Omicron. And as Tim said, there is science and labs that are purring along. And just this morning on Twitter, I was able to read that one group has compared the ability of Omicron to bind to the human receptor versus the rodent receptor. And they've shared that data already. And another group has looked at whether it interacts better with the larger airways, which is called the bronchus, than down lower in the lungs. And it seems to be differential in its ability to bind higher than lower down in the respiratory tract. And these are very early, but it's really incredible to see how fast the science is moving, because somebody told us there's a variant and because the reagents are there. So I too am optimistic that the science is really going to lead us forward here.
Mm-hmm. Wonderful. So let me jump for a moment. You sort of were touching on a little bit, Dr. Evans, about sort of how Canadians in particular have sort of behaved well from a public health perspective. So I'd like to sort of get both of your thoughts on what we can now do. Here we are, December 15th, the holidays are just around the corner, as is winter. What can we personally do to stay protected? So, yesterday here in Quebec, the government advised all non-essential employees to go back to working from home full time if possible. I know there are some sort of, contradicting opinions or policies in terms of holiday gatherings and those perhaps increasing in size. So I guess my first question is, do you expect government guidelines to change in the coming days based on new information?
I'll jump in on this and look forward to Marcel's points, but I'm sure there will be changes in government guidelines as we learn more. Hopefully they'll be based on evidence and good science, which isn't always the case, but hopefully they will be. But let me start by saying I think Canadians are well prepared at baseline insofar as well-trained, understanding all the risks, understand the importance of appropriate distancing, good ventilation, avoiding enclosed areas with large densities of individuals. And so I think if people exercise their common public health sense, then they'll manage the holiday season in such a way to minimize their own personal risk. In addition, I do think the increased availability of rapid antigen tests is going to be helpful. These things have been locked away from Canadians for far too long. And I think if they do have access to them, then self-testing will help be an additional risk mitigation factor, especially during the holiday season. So if you test yourself before having a gathering, or if everybody who's coming to the gathering tests themselves and they're all negative, then that's very positive. Or if somebody tests positive, then they remove themselves from that gathering. So these are, I think, that's an additional thing that makes me confident that again, Canadians will manage the holiday season in such a way that will not see a huge surge in cases.
Mm-hmm. So on that question about the rapid test, and I was going to ask you specifically about that, how much confidence do you have in, I guess, the accuracy of these test results we might get from the rapid test, and secondly, the confidence in people to be able to test themselves properly? And I don't want to get too granular, but most people don't know how to use, they've never used a rapid test stick. Are they simple to use? How far up your nose are you supposed to put this? I mean, so what level of confidence do you have in our ability to use these tests accurately and well?
Yeah, so I think Marcel should come in on the specifics of this, but what I'd say is, most the ones that I've seen and used, it's not rocket science in terms of how to use them. There will be a little bit of variability, I'm sure, but they were designed and have been tested, and they're not perfect by any means, but I think they provide additional reassurance for people, and are not sufficient in and of themselves to suggest that if they are positive that you definitely have COVID, you need a confirmation test with the RT-PCR. But I think as an adjunct to what we're doing, I think we can manage the variability in their use for an overall net positive benefit. But Marcel, it'd be great to hear from you on that.
Yeah. So the way we discuss lab testing, Derek and Tim, in the clinical micro lab, is we say that for every test, there's what's called a pre-analytic phase, an analytic phase, and a post-analytic phase. I know it sounds kind of nerdy, but the pre-analytic is whether you put it in your nose right. And fortunately, we know from a lot of studies that the sensitivity of testing nasal swabs and saliva are pretty comparable. So if you follow the instructions, you're going to be able to get it into your nose, and you should be able to get it out of your nose. The analytic question is whether it detects beta, delta, and Omicron. And all the data I've seen to date tells me that these rapid tests will also detect Omicron. So we're not missing Omicron selectively with the tests. That would be problematic. The post-analytic is whether you can read the red and the blue bar. And a lot of people we know have read these rapid tests at home, and they're called women who are pregnant. And we know how they work, and we know that they do work. I believe that in the 70s or so, when these were developed as pregnancy tests, the medical community pushed back and said people won't be able to read it. We shouldn't release the tests. But in fact, people do read it, and people do get the right results. So I think we have to have confidence, as Tim says, in the Canadian public to be able to follow the instructions and read it. They're not perfect, but having a negative test is better than not being tested.
Okay, wonderful. Good advice for both of you. So I should mention we've received quite a number of questions that have come in while we've been on the air. So I do want to turn to those in a minute, but I guess I had two more questions just on sort of personal guidance you might want to share with us. One was specifically around holiday gatherings and what advice you might have for those of us who are contemplating either hosting or taking part in participating in family gatherings, gatherings with friends. Any advice on that?
Well, obviously, the start is that you have to follow the guidelines. You have to follow the rules. That said, I'm a bit surprised that the government at Quebec website is now saying we're going to go from 10 to 20 on December 23rd. And I'll be interested to see if those guidelines change back to 10. So at this point, I wouldn't be sending out evites to 30 or 50 people, because I don't think you will be allowed to have 30 people, and you might not even be allowed to have 20 people if cases continue to rise. So my first piece of advice is to just monitor what public health recommends. I'll defer to Tim for his holiday plans.
Mm-hmm. Yeah, well, I'm always lucky in my holidays if I can get anybody to come to a party with me. So, but I think following those guidelines is important. I think expectations on full vaccination are very, very important. Two, I think with the rapid antigen tests available or increasingly available, you could ask people to do those tests. Three, organize gatherings in such a way that you avoid small spaces and intense density. I think there's all sorts of ways in which people can be creative on that front. And third, rather than just having one big party, have 5 smaller parties with smaller numbers. So think about ways of avoiding what we know are serious risks, which is large numbers of people getting together in small spaces. That is a recipe for transmission. We're seeing that all over the place at the moment, especially with Omicron.
Mm-hmm. And some of the early super spreader events happened in choirs. So if you go to Tim's house, make sure he doesn't sing.
Okay, is that a pandemic rule, or that's just a general broad regular policy we should follow?
That's always a rule. Never go anywhere where I'm singing.
Good to know. But yes, I have heard that about the singing and choirs as well. Last question before I turn to the ones from our alumni, and then we're getting quite a few. What about travel? Any guidance on people that are planning trips or have at this point trips planned, particularly outside of Canada? Tim, I know Dr. Evans, you'll want to jump in on this one.
So on this, the train has left the station. We have sustained community transmission of Omicron. So I think there is no benefit from travel restrictions at this point in time. And I say that very, very pointedly with respect to the travel restrictions that were slapped on Southern African countries. I think that is poor foreign policy, which reeks of colonialism, if not racism. So that on us, not something that I in any way condone or endorse. In terms of, I think very important to recognize that if you do travel, it's important that you're sensitive to where you're traveling to, and that you're not in any way a risk or creating risks in the countries that you may be traveling in. So there's no paradise where you can throw public health behaviors into the wind. I think you need to follow good behaviors everywhere. And I think if you do, then I think you can travel safely.
Okay, wonderful. Good to know.
The only other thing that I read on social media today is if Canada imposes travel bans to holiday destinations, we will prevent Canadians from seeding the holiday destinations. So if there are travel bans, they're probably more in the vested interest of our hosts than of our travelers.
Okay, great. So let me turn to, like I said, we've got a number of questions that have come in. So one question which I was going to ask you, Dr. Evans, was about this notion of vaccine equity, because I know we've talked about this quite a bit in previous webcasts, and there were sort of 2 questions that have come in on the same topic. So one came in from Patricia Riley, who was asking, will it truly require global vaccine equity and uptake to significantly reduce the likelihood of variant development, since every new infection is a potential host for a mutation. So maybe I'll stop there, and then I'll go to the follow-up question from another viewer after that. So, I mean, we've talked about this before, but so where does the whole issue of vaccine equity fit in? I mean, I know, we don't want to sort of point to South Africa as the birthplace of Omicron. They're really the ones who discovered it. But we also know that in sub-Saharan Africa, I think something like 4% of the population is fully vaccinated. So what is the connection between these low vaccine rates in some countries and, the fact that, viruses are going to continue to mutate?
I think, first of all, on the question of access to vaccines, we certainly have the global production capacity so that everybody can be vaccinated. And we've been way too slow in making sure that we avail that opportunity to everyone. And I think that's an unfortunate legacy of 2021, that even the expectations to get 20% of everyone in the world to full vaccination have fallen short. And it's something where we have a huge amount of room for improvement. So I'm confident that we can, and I think now we have to up the bar, because full vaccination, at least with mRNA in its current form, is now 3 doses, not 2. So we have to be readjusting our targets and putting those very squarely in front of us in the context of 2022. But I'm also encouraged by the fact that Canada has a new vaccine entrant in the context of Medicago, and I'm very optimistic that once that's approved, that we can be not simply an advocate, but also perhaps a little bit more proactive on the global vaccine equity front. In terms of the risk related to variants, I think insofar as the epidemic continues to have dry tinder to burn, insofar as populations have inadequate protection because of a lack of vaccination, then we'll continue to see prolonged and continuous evolution. Not all of that evolution will be bad, but some of it may be. And insofar as that risk continues, we're much better off fully vaccinated. So that's where I'd say on with respect to the risk of further variants and vaccination.
So on that point, I've got a great follow-up question that's coming from Diana Colby, a colleague of ours here at McGill. So she's wondering about the debate here in Canada about moving forward with a third dose, the so-called booster shot, versus ensuring equity and access to vaccines around the world. So how do we give preference to our third shot when so many people in the world are still waiting for their first?
So, I think this is not the first time we've run into this. We ran into this also in terms of whether children should get vaccinated now versus using those doses to support further vaccination in countries where there's insufficient vaccine. I think in face of the evidence on the benefit of a third dose in the context of Omicron, there are very few governments that are going to suggest that we shouldn't be moving forward with the vaccine with the third dose at the appropriate time. And the evidence of protection, I think, makes it clear that we will see third dose not be seen as a luxury and security blanket, but as really part of the vaccine regimen. It should have been perhaps 3 doses all along. And I think given that reality that is sinking in, it'll be very hard to make a suggestion that somehow those third doses should move elsewhere. The only thing I'd come back to say, though, is that our production capacity for vaccines is growing rapidly. And we really need to have, as I said, a 2022 concerted effort to get the world fully vaccinated. And on that front, as I said earlier, I believe that's possible and the right thing for us to do and focus on.
Okay, great. Well, a great answer and great questions. Thank you, Diana and Patricia, for those questions. Dr. Behr, I think the next couple of questions I'll turn to you. This one has come in from Rashi Carr. She writes that a recent report from the Canadian Medical Association sounded the alarm around collateral damage caused by COVID, with significant backlogs that will take many years, lots of money, and lots of innovation to overcome. Can you please comment on why you're so optimistic about catching up on the significant number of missed care opportunities?
So thank you for the question. I have to admit that I have not been able to read every article in every journal, and I don't know which of these backlogs are being referred to here. There are, of course, when the lockdown started, I spoke to our chief of surgery and I asked, how are you managing it? And they had a system in place to determine whether something was considered life-threatening surgery or quality of life surgery. So that if somebody had cancer, there would not be a backlog. And if they needed a knee replacement, there may be. So I don't know the details of that article, and I don't know which backlogs you're referring to. But I will obviously look at it after this conversation and see what they were what they raised as issues at that time. I'd like to think that although it was a shorter period, there was a smaller experiment with delayed medicine with SARS in Toronto in 2002 to 2003. And maybe Tim knows what was the long-term consequence of shutting down hospitals and shutting down elective surgeries for about 6 months. I know that the numbers of procedures did drop significantly, but I'm not sure if in the Toronto area they were able to document any long-term effects of that shutdown.
Mm-hmm. Well, I know, Marcel, anecdotally, it kept me from practicing, and that was a net benefit for the population of Toronto at that time.
Was that when you took up your singing lessons? Or I won't ask. I shouldn't ask.
Torture, another media.
Right. All right. Well, thank you for that. Second question for you, I guess, Dr. Behr. This one came in from John Rostin, and he's asking if COVID is going to be with us for the long term, should we be building specialized hospitals exclusively for COVID patients, both to provide them with the most appropriate care and to free up hospitals to provide healthcare for other diseases and conditions?
So, of course, this is a question that can be framed almost in historical terms. My specialty is tuberculosis. And after the discovery of the germ that causes tuberculosis in 1882, there were TB-specific hospitals created all around the world. Curiously, most of them are now ski resorts as TB drugs came along, and it was no longer necessary to keep people in Davos or at Lake Placid during their care. And so now people are sort of looking back and saying, should we have, COVIDariums? Or should we do the opposite, which is to say, well, what do we do if somebody is admitted with TB at the MUHC today? We put them in a room, we put them in negative pressure, we put a sign on the door, and we all wear masks, and we take care of that individual. And then if somebody in the room next to them has the flu, we can do the same thing. So there are really two polar approaches. One is to create a COVIDarium and send all the COVID to COVID-specific hospitals. But if you did that, then you wouldn't have a dialysis unit. And if that person had a heart attack, you wouldn't have a CCU. And if that person was on a certain treatment and they needed to get a consultant, if they had diabetes, you may not have an endocrinologist. The other pole would be to say that we should actually be normalizing or regularizing COVID care and saying this is integrated in the way that all hospitals operate all the time. And there would be protocols for COVID, but they would be the same as the protocols we have for somebody who carries resistant Staph aureus, for instance.
Mm-hmm. Okay, great question, John. And I actually have a quick quick shout out from Stuart McCombie, who's our technical director behind the scenes, who says he knows you and says, hi, John, out in Vancouver. So that's great. I will also let you guys know, Doctors Evans and Behr, that my office is telling me that the numbers of viewers watching seems to be climbing as we've been going on. So normally people are, bored and falling off, perhaps. I don't know, but a very interesting conversation. So let's keep it up. Let me see. I've got, like I said, a whole bunch of questions. I guess the next one I'll turn to you, Dr. Evans. This one came from Terry Baxter. So when Omicron becomes the dominant variant, does this mean that the Delta variant will disappear? And do we still have to protect ourselves from Delta?
That's a great question. And the short answer is I don't know. I don't, with respect to its disappearance, my sense is that it will become much less frequent. But I don't think I can say whether or not it will disappear at this point in time. But regardless, I think the best way to deal with Omicron and the best way to deal with Delta are the same. So using good public health behavior and making sure that you're fully vaccinated, those are things that I think remain viable strategies at the moment. And so yes, if there are other variants, and there will continue to be other variants, including Delta and some earlier variants, we should continue to be vigilant as we are. So that would be my answer on that, but I can't answer definitively whether it will disappear. I don't know that.
Mm-hmm. Okay. All right. Dr. Behr, here's the next question for you. This one from JJ. So you mentioned earlier that we have more available treatments for COVID now. The question is, can you elaborate on how that translates into availability of their use here in Canada, as well as what and how we are using them?
I cannot actually elaborate too easily because I find it's incredibly complex to go from the availability of things that are in warehouses to things that go into patients in the clinic. And as Tim mentioned earlier, there have been antigen tests in warehouses for a long time, and they've been withheld because they were considered to be imperfect. There have been monoclonal antibodies available since over 1 year ago when I started emailing a number of people about how we could bring these new monoclonal antibodies into our patients. And there's been a number of different bureaucratic or administrative or economic arguments against their use. And each one in turn, you can try to find a solution before somebody presents you with the next problem. Some of them are logistic. If somebody's an outpatient and they have new COVID, and they are contagious, you may not want to bring them into a hospital for treatment when we are screening people at the door and saying we're trying to keep the COVID on the outside and not on the inside. But for logistic problems, there should be logistic solutions. So briefly, it has been somewhat more complicated in the last 12 to 13 months than I expected. And yet there are promising data from a number of clinical trials for both drugs and monoclonal antibodies. And I do hope we use them where appropriate and in the people who are at highest risk, especially people who are immune compromised and vaccinated, but their immune system didn't work and couldn't mount a very strong response. We do have these available, and we are offering them now at the MUHC when people come in, and I hope we can deploy them effectively.
Mm-hmm. Okay, great. So let's go now. We've got a question that's just come in from Mark Thibodeau. Maybe Dr. Evans, you want to answer this one? We'll see. So he's asking, is it fair to say that vaccinated people simply need to stay out of the way of unvaccinated people? And if I stay in contact with vaccinated people only, is it fair to say that I live in a safe environment?
First of all, you may not know if you're in contact with somebody who's not vaccinated. And if you are in contact with somebody who's not vaccinated and you know it, you should be exercising good public health precautions. So those are, I think that's fair. But even when you're with people who are vaccinated, as we're seeing, given the levels of breakthrough infection with Omicron, you need to continue to exercise good public health behavior. So again, these are things that suggest that trying to become overly dependent on a single public health measure like vaccination is a mistake. Vaccines are critical and an important part of the bigger picture, but so too are wearing masks, social and physical distancing, and looking at how to manage your exposure in crowds. So I think those are the things, we all know them, and we need to exercise them, especially at the current time, meaning the holiday season, waning immunity, if we haven't had our third dose, and this new variant.
Okay, great. So we have time for a couple more questions. Let me go back to Patricia Riley. She'd sent in a couple of questions earlier as well, both about Omicron. So our questions are, how long will it take to learn about other vaccine effectiveness against Omicron? So far, she's only heard about data from Pfizer. And how long will it take to learn about the long-term effects of the Omicron variant? Will Omicron cause fever or different long COVID symptoms?
Well, I could start with the vaccine data. What I've seen for neutralizing antibody data on social media in the last day or two compares Pfizer to Moderna, to one dose of Johnson & Johnson, to AstraZeneca, to the Sinopharm, and to the Sputnik. And maybe Tim has seen more, but people have looked at different groups of different vaccinated people, and there is a gradation between having very good, not excellent, but nonetheless very good immunity with some of the vaccines, to really no detectable immunity with some of the other vaccines. And these are obviously not peer-reviewed papers yet. These are scientists sharing their data as quickly as possible, but they look like they're from credible groups. They look like they're well-done studies. And so it seems that some vaccines are going to be better for Omicron than others.
Mm-hmm.
What was the second part of the question?
The second question was about symptoms from Omicron, and particularly long COVID symptoms, if Omicron is any different from some of the other variants, and when we might have more information on that.
I'll start with the symptoms, and I'll defer the long COVID to Tim. When you have a new strain that emerges and you say it is milder or more severe, I think you have to immediately look at the demographics. Who is going to Christmas parties? Who is traveling to certain places? And then you have to normalize your results to other people of that age, so that if Omicron is spreading in Danish people in their 20s, you shouldn't compare that to Americans in their 70s. And you have to be very careful to look at the data in an age stratified manner, and even to understand if people have comorbidities or not, before you can deduce that it's more likely to cause a fever or more likely to cause hypoxia. I think we need a little bit more data to see what happens. But there are places like Tim mentioned, like the UK, which are probably experiencing right now a natural experiment, where half of the people in the UK have Delta and the other half of the UK have Omicron. And once they genotype all of the people who have COVID today, we may be able to find out if the one half has more fever than the other half. In terms of long COVID, I now hand it over to Tim.
Great. Well, I would just add that the simple answer is we don't know in terms of the long-term effects. I think just as we have concerns about and are learning more about the longer-term effects of previous variants of SARS-CoV-2, there's going to be need to design studies to follow these things out and be sensitive to whether or not variants are an important stratifier of risk with respect to long COVID. Those are important prospective research questions. So I think that would be my deferral on that question. We need more research, and it's certainly a very important research priority. And it relates a little bit to what I think we may see more of in the context of Omicron, is that people who get infected but do not have any short-term symptoms. That may be a good thing in the short term, but it's much too early to say that there is perhaps no long-term sequelae or consequences of that for some fraction of the population. And I think we have to be suspicious of that, knowing what we know with respect to the longer-term symptomatology that we've seen arising with the other variants in the context of the epidemic today.
Mm-hmm. Okay, great. So we have time for, I guess, one more question. And this is a great question that's coming. I was actually going to ask you both about the Spanish flu of 1918 and how that ended, and the fact that there were actually no vaccines back then. But we've got a great question that came in while we were on the air from David Fine. And his question is very similar. He wants to know if the history of previous pandemics teaches us anything about how this pandemic might evolve. Can we expect COVID to become mellow and less lethal over time? So maybe think about that question and my question about, how did we get out of the 1918, not us, but our ancestors? Where does this end? I mean, how do you think the pandemic might end?
So if I tackle the 1918, I'll hand over the exit strategy to Tim, because I think he actually wrote an op-ed maybe 18 months ago about the exit strategy. So it's time to revisit that. The 1918 strain did not disappear. It evolved and it mutated, and it was around until at least the 50s, and then it disappeared, and then it reemerged in the 70s. And there's a theory there may have been a lab accident, but that's always hard to prove. But while the pandemic of 1918 did not go away, the pandemic settled, the virus did not go away. The other thing is the Spanish flu also reminds us about misnaming a strain, just like calling something the South Africa strain. It's my understanding it was called the Spanish flu because the countries that were at war had a very controlled press, and they didn't want to have the other side know that their boys were sick. So it was described in a country that wasn't at war because they didn't have a controlled press, and they could say there was a flu pandemic going on. Mm-hmm. So we shouldn't assign viruses to countries and then blame them for a pandemic any more than we should be doing that for Omicron today. But Tim, I think you wrote about the exit strategy last year, and it might be time to reawaken the thoughts of what is the exit strategy in 2022.
Mm. Well, thanks, Marcel, for that simple question. And it's always a good one to end on, because the longer I hum and haw, the shorter my answer will be. And the short answer is we're still sort of peering into the dark on that. However, I do think we've got important dimensions of it. First, we shouldn't forget that science is delivered in the best way possible with respect to not only vaccines, but a host of therapies. As Marcel said, if we can make sure that we don't neglect those and take the ones that work for appropriate populations, then we'll get much better at minimizing the morbidity and mortality, the sickness and the deaths associated with this. So I think we can move together with good behaviors, good public health behaviors, to addressing this virus in such a way that it is no longer a public health threat. I think it will hang around for a long time, and we will have to have good vigilance such that if it does crop up again in ways and our guards are down with respect to our protection, we can mobilize that quickly. And I say that because it's not just what we do here in Canada, it's what we do globally. And I think we can't forget that we are all in this together, or we're not going to be as safe as we could be until we're as safe as we can be globally. And on that front, I'll conclude saying our 2022 New Year's resolution needs to be around making sure that everybody everywhere as the opportunity to be safe and protected from this virus. Absolutely doable. We've got the knowledge and the know-how. We just need to have the political will and conviction to make it happen.
Wow. Well, wonderful closing words from the director of McGill School of Population and Global Health. You couldn't ask for anything better. So that just about wraps up the time we do have today. I think we've actually gone a little bit over, but this has been an incredibly insightful conversation. And I first of all, just want to remind everyone who's watching this video that it will be available as well at this very same link soon after our recording ends. So feel free to share with others who may not have been able to tune in live today. And of course, I'd like to extend my deepest gratitude to our two panelists, Drs. Tim Evans and Marcel Behr, for taking the time out of their very busy schedules to join us today and offering their usual mix of great information and, not so horrible humor from time to time. So, you've made it entertaining for us and a bit lighthearted as well as extremely informative. So thank you both for that. Please stay tuned to your McGill email and social media feeds for more updates on our alumni programming in 2022, including hopefully a return visit from our two doctors, as I think it'll probably be appropriate to have an update maybe later in the winter or early spring as the pandemic evolves. And to all of our McGill alumni and donors and viewers all over the world, please accept my best wishes for a happy, relaxing, and safe holiday season. Thank you.
Thank you, Derek.
Thanks, Derek. Thanks, Marcel. Thanks, Stuart.